And what if people choose not to follow through on our recommendations? Can we terminate services? Well, in theory, yes, we could terminate, or we could say, I can't work with you this way. But we have to really be careful, and more careful than we used to be. Crane last year wrote a really, I thought, a useful article about how the environment has changed, about our ability to kind of just discharge people and say, well, you're not complying, see you later. Okay? That we have to be more attentive to a number of factors, including get clarity about why are people not complying. In the situation you raised, the person saying, I just don't want to do that, but it might be important to say, well, how come? Or I can't make it to therapy as often as you want me to. Is this a money issue? Is it a transportation issue? In the environment that I was mentioning before, where before we started filming, where we have a lot of folks who are low income or no income, and they're on subsistence, transportation is a major concern. Even if they get vouchers, it may take a person an hour and a half or 2 hours via bus to get to an appointment. And so if they've got 2 or 3 appointments that day, they can't make them all. So asking, did you lose a job? Do you not have the necessary financial resources to get services? And as a result, what Crane argued is that we should be thinking about making referrals for people if that's legitimate, and if there's a reason they give us for not being able to get services that is about our not being able to provide it, making referrals on to another low-fee clinics, organizations. And he suggests remaining connected and knowledgeable about community resources for clients to increase the likelihood that clients will be able to use services. Now, one of the things that he asks for that I know in many situations can't happen is asking clients to report back what happens when we make referrals. You know, one of the kind of a classic issue is a drift-away client, somebody who just stops coming. And you try to contact them and they don't get it back in touch with you, or you make a few efforts and you hear nothing. Your client may not report back, but then the next option that Crane suggests is if you think there are risks, if they don't get the services, letting them know and letting them know in writing. Okay. So whereas maybe 15 or 20 years ago when we discontinued services because a person was non-compliant, we might do a summary and we might explain why for our own records, but Crane is arguing that we really need to go further currently, particularly if the person is saying that they don't want to comply with our recommendations. They don't want to do the kind of treatment that we're suggesting. And it follows from, I'm going to go back for just a sec, from the Truman versus Thomas case, but also the ideas underlying Ashraf. People get to decide, and we have to engage in informed consent, including informed consent about not what will happen if they don't get service. Non-compliance with treatment recommendations, as Crane suggests, used to be a lot easier. I mean, in the old days, if he drifted away, we would say, he gets to decide, right? But there are more clients who are complaining, and sometimes, I'm not saying complaining in a negative or kind of in a manner that's intended to be pejorative, who are making often legitimate complaints about not having explained to them what would happen, for example, if they stopped using a medication all of a sudden. Great example was a colleague who was working with a woman who had been on benzodiazepam for a long time. Now, as many of you may know, withdrawing from that stuff can be really tough. And there are psychotic-like symptoms that can sometimes be mirrored. You can have all kinds of sleep disturbance. And it is truly a withdrawal experience. It's not just you have some mild discomfort. The primary care doc who was providing her with these medications and who had prescribed them to begin with said, oh, yeah, they're not working for you to help you sleep and so forth any longer, so you can just stop them. Really? Can I just stop them? Oh, yeah, go ahead. Well, this client had seizures as a result of having stopped them precipitously and made a complaint against the physician that the physician did not inform her of the potential outcomes of precipitously ending her use of benzos. And not that she didn't want to go off them, but she wanted to be staged off them and reduce the likelihood of there being negative outcomes. That, if she didn't sue, but she did complain to the organization within which that person worked. So folks are making those complaints, and there are at times legitimate bases for those complaints. Sometimes also there are arguments that the information was given in a way that was not understandable. Whether it's good news or bad news, you must have given that information in a way that was understandable. It upset him.
Yes.
Okay? And now, maybe he misconstrued it, but it sounded much more like you said, look, this is a real problem. Now, it can cause people to get really upset, so we can't chase them. But we do need to try to take the opportunity, if we can, as Crane suggests, to write a risk letter and to do it in as client-friendly a fashion as we can. And it won't necessarily insulate us from people doing the kind of complaints that you're describing. Okay. Still, it's very interesting. This is about those that kind of earlier cases, ones that started in the 1980s, that are now, in some respects, coming to roost. We're seeing this idea of informed consent and non-compliance becoming a much more prominent discussion. Nothing's going to immunize us to being liable if somebody sues us and we don't already have legal kind of quasi-judicial immunity like with child abuse reporting, but it improves one's position because what you're doing is you're basically saying, look, here's what I'm worried about. There are some risks here. You get to decide this. I respect your decision. Here's what I worry about. Here's some of the things that may be problematic. And certainly if you don't want to work with me, I understand. I'm happy to make referrals for you. So that kind of approach can be really useful, and it does reduce, part of what Crane is arguing is that it reduces the likelihoods of liability. I'm thinking of it more from a perspective of the liability as an issue. It's kind of a consequentialist view. I'm thinking of it more of a perspective of really trying to be sure that people who are getting services from us understand what happens in their choices as best we can help them do that. And we can by no means be assured of it, but it increases that likelihood that there'll be an understanding here. As you can see, and most of these are pretty straightforward, did I say, I think about 5 of these, I say document. You've got to really be careful to document the letter if the person doesn't receive it. Document what you've said, explanations that you've given in language that the person can understand. If you can find the person, providing a copy to them, and document whether the person refused to comply or complied. In your case, there was no basis or no need to document because you knew exactly what was going on. But you want to document they refused. They refused to do this. Because even if he's very angry and complaining and suing or trying to sue, he could still be suicidal. That's the thing that's so tricky. Again, clarifying consequences of not following through, which is exactly what you did. And if the person's non-responsive, we can certainly end services, but of course if they're already choosing to end them, it's not as if we're the one who's initiating that. We want to be really clear that we document that that client has chosen to discontinue services and we've given them the information about what we think some of the risks are. Hartzell and Bernstein wrote an article a few years ago, about 5 years ago now, about what they called, Bernstein calls a discharge letter or a termination letter. Whenever somebody ends or when you have to end with them, he went through a long laundry list of things to include in letters to clients about that. I think it has to be artful, and having it be purely legalistic can be as much problematic as failing to let people know that therapy will be ending. So there's a balance between giving all the detail and making sure that you inform, and also not having the client feel like it's just a cover my butt exercise. This is related, at least to some extent, to the issue of written informed consent. APA's ethics code, CAMF's ethics code, does not require a written informed consent form. It says we have to document it, but that's different than you're my client and I say, here's a form, sign it. Okay? Most counties, most larger providers have a specific form, and that's just one example, for example, of Alameda County Behavioral Health Services, healthcare services. There are exceptions to forms even when the organization may require it. For example, if it's an emergency, you don't need to get a signature from someone who is refusing services, imminently suicidal, you're trying to hospitalize them. You try to inform them, but having it in writing is not realistic. Interestingly, consent forms have caused some debate. I did a study a number of years ago. Speaking of dissertations, this is what my dissertation was based. This was based on my dissertation. This study with Ami Elwork, that clear written descriptions of the limits to confidentiality actually do seem to reduce patient disclosures at intake. One of the parts I couldn't report in that study, and it was small. I just had 41 or 42 participants, and they were all in community mental health services. And I had half of them assigned to a minimal information condition, which essentially was what the clinic ordinarily did, which is a one or two sentence description of the limits to confidentiality versus about a page or a page and a half description of the limits, including things like more confidentiality for substance use, less confidentiality for things like when you say you're suicidal or child abuse and that sort of thing. What I found was that I asked the therapists to, 3 weeks into treatment, follow up and rate the same forms about their client disclosure. I didn't get enough therapist response to include it in the study, but it was the same differentiation. The people who got the full informed consent, the therapists were saying they were less disclosing in the first few sessions. Couldn't publish it. It's probably not reliable information, but the trend was there. You know, at least it seems so to me. So some folks have argued over the years that informed consent does harm, and that written informed consent may be problematic. In fact, there was a study that was published by Dos Douglas and colleagues about the shifting in San Francisco from a written consent requirement for HIV testing to what's called simple consent, or an oral then documented consent for HIV testing. We saw a huge increase that year in HIV testing in San Francisco. And that article said this made, this easier consent process made a huge difference. Interestingly enough, Goldman and colleagues in New York noticed the same upsurge that year, and they made no such change. So it may not be related to informed consent per se, but there are folks who've been making this argument over the years that the written consent process is not a great one. This is an area that I've been interested in since I've been in graduate school, and I began to wonder about whether it may have to do partly with how one does the written consent as much as the fact of the information. Because I'm giving it similar information in the written and oral, why would the written consent form make a difference, right? If people are actually doing the oral consent. And although it's from a different direction, there is some indirect evidence here about this particular issue that comes from domestic violence research. There was a study that Paternoster and their colleagues did about the experience of men who are arrested for domestic violence offenses, and whether their reoffense rate increased as their experience of disrespect by police, judges, and other people in the system, and whether it decreased as they experienced respect from people, that they're not treated as that they're like they're filth. They're just treated as you did something that's illegal. We're going to prosecute you. You have rights. Blah blah blah. And they found a really interesting trend. It's again not proven, that the men who experienced respect in the system had fewer recidivism episodes. And you'd think with something as multi-determined as domestic violence, this would not show up at all. But how people are informed of information makes a difference, at least from my view. From a liability perspective, though, I have to tell you that I believe that not using an informed consent form is just foolhardy. There's no other way to chronicle that consent really happened, because if you don't have a person's signature on a form, and I don't think that's enough, by the way, but if you don't have a signature on a form, then a person has to say, well, they said that they told me about consent, but they didn't. I don't know how many of you have been working in or around psychiatric facilities, but it's very common for physicians when they prescribe, psychiatrists when they prescribe medications, to say, provided informed consent in the note, and then sign the note. And if you ask clients whether they got the information, they'll say, what information? Now, giving everyone the benefit of the doubt, I wouldn't be surprised that the physicians are actually explaining things. But because it's so perfunctory, and also because it's just verbal, it's not being perceived and processed. And then it's really difficult to demonstrate that the person actually even took a look at the form, that there was a form, that there was information that was provided. So from a liability perspective, an informed consent form, I think, is absolutely essential. I just encountered in some of the literature some kind of pushback in a sense that recently about, well, written informed consent is really problematic. And so partly what I'm responding to is, and I understand why. I mean, some of my own research suggests that it could have negative outcomes. So it's not like I'm disagreeing with some of the underlying, kind of the empirical data about it, but I do think that there is an overarching ethical mandate to do this.
What does HIPAA say?
Well, HIPAA doesn't say anything about informed consent. HIPAA has a notification requirement. That's not informed consent. So the notice form that we're supposed to provide about privacy practices, it's not an agreement or a disagreement. We only have a duty to do a good faith effort to have people review and sign it, but if they refuse, we can keep doing our own privacy policies just like we would if they'd signed it. So it's truly not informed consent. And let's be real about this. How many have read completely the HIPAA forms that you've gotten at physicians' offices? Nobody reads those things. I, because of my high PA on the MMPI, read them. That's because I went to law school, even though I'm not a member of the bar. And I read things that are often wrong. Or if you actually read through the HIPAA forms, you wouldn't say anything to anybody. Because it's all open. You basically get to exchange whatever information you want, except for if it's in, for example, the psychotherapy note. But as most of you know, the difference between a psychotherapy note and a progress note is a matter, well, arguably of degree, not kind. So HIPAA doesn't say anything about informed consent, just notification. There are some studies. Most of those took place in the 70s and 80s. There were some in the early 90s. I haven't seen any recently, although that literature I haven't been following as closely in the medical field, more in psychology and in psychotherapy. And the comprehension levels are pretty low. There have actually been suggestions of giving people quizzes, which I think, can you imagine? Hold on a minute, I got to give you a quiz. I just, it's... Yeah, right. But there have been some very inventive ways of trying to do that, saying, for example, so here are the procedures. Now, I want to be sure you understand. Could you tell me back what it is that you understand the procedure to be? And on the surgery side, that's getting much more sophisticated. But the understanding, the comprehension levels have been pretty low. And there have been, even with, interestingly enough, Litz and Roth and colleagues did a study that was published in the middle 80s. It was called the Informed Consent Studies. It was done at Western Psychiatric in Pittsburgh. And they studied whether people who were psychiatrically impaired could understand and engage in informed consent. And their overall findings appeared to be, and it wasn't a controlled study, it was, it was kind of a non-randomized and so forth, but their overall findings and impressions, which I think has some weight to it, were that the comprehension levels were at about what medical patients' comprehension levels were, at least, and with efforts to help people understand, they improved considerably, even with folks who were floridly psychotic. So they actually made the argument that there's no reason to fail to do informed consent with people who are experiencing psychiatric illnesses as opposed to medical context. And for many of us, we're working with people who may not be floridly psychotic. There's, I think, an even better argument that we do the process and try to help people understand, do it in writing and verbally. I'm teaching the observation and interviewing class. And one of the things that this is our first year class, first interviewing class, where we're teaching like basic skills, empathic listening. Okay, so it's like 101, literally 101. And a number of students have raised the issue, well, are we supposed to do an informed consent process? And I said, absolutely. So part of the process is to model for my students, and for the folks you work with, how do you do that verbally in addition to having it in writing? So it flows and it's part of the relationship building. Not that it's just this extraneous, I give you this piece of paper, you do it and we're done. But how to make it part of the interview so that people know the structure of the relationship and it actually is a jumping off point for having conversations if there are concerns. I kind of keep my ears and eyes open for people talking about, kind of iatrogenic effects of informed consent. And there are a few that I've heard, one of a person who was seeing a lawyer, and the lawyer basically rewrote their consent form for them, right? but it was in some ways diagnostic. I mean, this person he could not back off of the role, and also was so obsessive about things. So the clinician actually said that it was a great jumping off point. You know, it was really useful. And then another where a person saw the consent form and said, well, I thought this was a place I could talk to people, but you're saying that, like, if I say I'm going to hurt somebody else or I hurt a child, you know, you have to report that. I'm not talking to you. I'm not going to do this. As sad as it may be, I think that's the person's right, and they should know beforehand. That's my perspective.